Let's review hereditary white cell conditions that show distinctive morphological changes. Alder-Reilly anomaly is a condition in which white cells contain large azurophilic granules. It is associated with mucopolysaccharide storage diseases, such as Hunter syndrome and Hurler syndrome. Although the granules look abnormal, the underlying cause is defective mucopolysaccharide metabolism. Chediak Higashi syndrome is characterized by large lysosomes that result from the fusion of primary granules. Clinically, it is associated with albinism and increased susceptibility to infection because the neutrophils cannot kill bacteria effectively. This condition can be life-threatening in childhood. In Hegglin, we see large platelets, often reduced in number, and the presence of Dohle-like bodies in neutrophils, monocytes, and lymphocytes. Despite the abnormal appearance, this condition does not affect leukocyte function. Some patients may have mild bleeding due to the platelet abnormalities. Pelger Huet anomaly involves hyposegmented neutrophils, sometimes referred to as pince-nez cells. Despite the abnormal nuclear shape, these neutrophils have normal function. It is important to recognize this hereditary condition to avoid misdiagnosing it as a left shift or myelodysplastic process. In summary, Alder-Reilly, large azurophilic granules linked to mucopolysaccharidoses. Chediak Higashi, giant lysosomes associated with albinism and infection risk. Hegglin, large platelets, Dohle-like bodies, but normal leukocyte function. Pelger Huet, hyposegmented neutrophils, normal function. Myelodysplastic syndromes are neoplastic clonal stem cell disorders. They are characterized by cytopenias in the blood and dysplastic changes in the bone marrow. In refractory anemia, blasts are less than 5%. In refractory anemia with ring sideroblasts, blasts are also less than 5%, but distinctive ring sideroblasts are present in the marrow. In refractory anemia with excess blasts are increased, ranging from 5 to 20%. This condition can progress to acute leukemia. Myeloproliferative neoplasms are neoplastic clonal disorders. Unlike MDS, they are characterized by increases in red cells, white cells, and/or platelets. Here are the myeloproliferative neoplasm subtypes. Primary myelofibrosis often shows a dry tap on aspiration because of bone marrow fibrosis. Teardrop-shaped red cells are a classic finding. Essential thrombocythemia is defined by excessive platelets, often more than 1 million per cubic millimeter, with increased megakaryocytes in the marrow. Chronic myelogenous leukemia features increased myeloid precursors at all stages. The leukocyte alkaline phosphatase, or LAP score, is decreased. The hallmark is the Philadelphia chromosome, a translocation between chromosomes 9 and 22, creating the BCR-ABL fusion gene. Polycythemia vera is a panmyelosis disorder with increases in all marrow elements. It is strongly associated with the JAK2 mutation. Acute myeloid leukemia is defined by more than 20% blasts in the bone marrow. WHO divides AML into several subgroups. AML with recurrent chromosomal abnormalities, as seen in 1, translocation 8, 20 leads to myeloblasts with Auer rods. 2, inversion 16 or translocation 16. 16 is associated with abnormal eosinophils. 3, translocation 15, 17 defines acute promyelocytic leukemia. And 4, chromosome 11q23 abnormalities are linked to monocytoid precursors. Other groups include AML with dysplasia, therapy-related AML, AML of ambiguous lineage, and AML not otherwise specified, which defaults to the FAB system. The older French-American-British system defines AML as having greater than 30% blasts. It is based on morphology and cytochemical staining. Although replaced by WHO criteria, it is still useful historically and in some exam contexts. Let's go through the French-American-British FAB classification of acute myeloid leukemia step by step. Each subtype is defined by the predominant cell type seen in the bone marrow. M0, myeloblast without differentiation. This form of AML shows very immature blasts with no evidence of differentiation. The cells resemble primitive stem cells. M1, myeloblast with minimal maturation. In M1, the blasts show slight signs of maturation, but most remain undifferentiated. M2, myeloblast with maturation. In M2, there is a greater degree of maturation among the myeloblasts. This subtype is one of the more common presentations of AML. M3, acute promyelocytic leukemia, APL. In M3, the predominant cell is the promyelocyte. This subtype is highly associated with disseminated intravascular coagulation, DIC, because the abnormal promyelocytes contain procoagulant granules. It is linked to the T1517 translocation and is treated with all-trans retinoic acid, ATRA. M4, acute myelomonocytic leukemia, AMML. In M4, both myeloblasts and monoblasts are present in significant numbers. M5, acute monoblastic leukemia, AML. Here, the marrow is dominated by monoblasts. This subtype often presents with extramedullary disease, such as gingival hyperplasia. M6, erythroleukemia. In M6, the abnormal cells belong to the erythrocytic series. This subtype is also called erythroleukemia and is relatively rare. M7, megakaryoblast leukemia. In M7, the abnormal cells are megakaryocytes or their precursors. This form of AML is seen more commonly in children and patients with Down syndrome. In summary, the FAB classification system categorizes AML into M0 through M7, based on which cell line dominates. It provides a morphological framework that is still useful for exam prep and clinical understanding, even though WHO classification has replaced it in practice. Let's review the recurrent genetic abnormalities seen in acute myeloid leukemia, or AML, and the characteristic findings associated with each. T1517, retinoic acid receptor alpha gene. This abnormality is the hallmark of acute promyelocytic leukemia, APL. It involves a translocation between chromosomes 15 and 17, which disrupts the retinoic acid receptor alpha gene. Morphologically, you will see promyelocytes with multiple Auer rods, sometimes clustered together in so-called faggot cells. Clinically, this subtype is strongly associated with disseminated intravascular coagulation, DIC, but is uniquely responsive to treatment with all-trans retinoic acid, ATRA. T8:21. This translocation is typically seen in AML with myeloblasts showing maturation. These cells frequently contain Auer rods, slender needle-like inclusions of myeloperoxidase. Patients with this abnormality often have a relatively favorable prognosis when treated appropriately. T1616 or INV16. Both the inversion of chromosome 16 and the translocation between two chromosome 16s are associated with a distinctive AML subtype. The marrow shows a mix of myeloblasts and monoblasts, along with increased eosinophils that have abnormal granules. This subtype also tends to have a favorable prognosis with intensive therapy. In summary, T1517, promyelocytes with multiple Auer rods, acute promyelocytic leukemia. T821, myeloblasts with maturation in Auer rods. T1616 or INV16 : myeloblasts, monoblasts, and increased eosinophils. These genetic abnormalities not only guide diagnosis, but also carry important prognostic and therapeutic implications. Let's review some lymphoproliferative neoplasms, beginning with acute lymphoblastic leukemia lymphoma, ALL/LBL. Acute lymphoblastic leukemia and lymphoma are divided into precursor B-cell and precursor T-cell types. Precursor B-cell all expresses CD10, CD19, CD22, and CD24. A common genetic abnormality is the translocation 12. 21, which creates the ETV6-RUNX1 fusion gene. Precursor T cell. All expresses CD2, CD4, CD5, and CD8. It often presents as a mediastinal mass, especially in adolescence. Chronic lymphoid neoplasms, CLL and HCL. Chronic lymphocytic leukemia shows mature lymphocytes with a characteristic soccer ball nuclear pattern. These cells are positive for CD19, CD20, CD23, and CD5. Hairy cell leukemia features lymphocytes with cytoplasmic projections. Clinically, it causes pancytopenia and splenomegaly. The immunophenotype includes CD103 positive, CD11C negative, and CD25 positive. Prolymphocytic leukemia. This condition is defined by more than 50% prolymphocytes in circulation. It is most often of B-cell lineage and tends to be more aggressive than CLL. Plasma cell neoplasms. Multiple myeloma. Multiple myeloma presents with bone pain and multiple lytic lesions. The bone marrow is filled with sheets of plasma cells. On peripheral smear, red cells form rouleaux, resembling a stack of coins. Laboratory findings include a monoclonal protein spike, usually immunoglobulin G or immunoglobulin A, hypercalcemia, and urinary light chains known as Bence-Jones proteins. Plasma cell variants. Plasma cell leukemia occurs when 20% or more of circulating white cells are plasma cells. Waldenstrom macroglobulinemia presents differently. The bone scan is normal, but IMG levels are very high, causing serum hyperviscosity. Hodgkin lymphoma. Hodgkin lymphoma is defined by the presence of the Reed-Sternberg cell. It spreads in a predictable, stepwise manner through lymph node groups. The incidence is bimodal, peaking in young adults and again in older adults. Burkitt lymphoma. Burkitt lymphoma is highly aggressive and associated with Epstein-Barr virus and HIV infection. It is caused by the T8:14 translocation, involving the CIO-MYC oncogene. The immunophenotype is CD19 positive, CD10 positive, and CD5 negative. Let's break down the differences between multiple myeloma and Waldenstrom macroglobulinemia. In multiple myeloma, there is significant bone involvement, leading to lytic lesions, bone pain, and pathologic fractures. In Waldenstrom, bone involvement is absent. Patients usually have a normal bone scan. In multiple myeloma, serum viscosity is usually normal or only slightly increased. This is because the immunoglobulins involved, IgG or IgA, are smaller molecules. In contrast, in Waldenstrom macroglobulinemia, serum viscosity is markedly increased due to the overproduction of IgM, which is a large pentameric molecule. This leads to symptoms of hyperviscosity, such as visual changes, bleeding, and neurological symptoms. In multiple myeloma, the abnormal protein is most often IgG, or sometimes IgA. Patients often have Bence-Jones proteins, which are free light chains excreted in the urine. In Waldenstrom, the abnormal immunoglobulin is IgM, specifically the heavy chain. This massive IgM production is what causes the hyperviscosity syndrome. In summary, multiple myeloma, bone lesions, IgG/IgA spike, Bence-Jones protein, mild viscosity changes. Waldenstrom, no bone lesions, IgM spike, marked hyperviscosity. Let's review important cytochemical stains, inclusions, and immunologic markers, what they indicate, and their clinical significance. The Prussian blue stain detects iron. It is used to diagnose sideroblastic anemia and iron overload conditions. Leukocyte alkaline phosphatase, LAP activity is measured in neutrophils. It is increased in leukemoid reactions and in polycythemia vera, but decreased in chronic myelogenous leukemia, CML. The peroxidase, or Sudan. Black stains detect myeloperoxidase and lipids. They are positive in myeloid precursors, but negative in lymphoid precursors, helping to distinguish between myeloid and lymphoid leukemias. The specific esterase, chloroacetate esterase, stain marks granulocyte precursors. It is positive in granulocytic lineages, but negative in monocytic cells. The nonspecific esterase, alpha-naphthyl butyrate, highlights monocyte precursors. It is positive in monocytic leukemias. The trap. Tartrate-resistant acid phosphatase enzyme activity is characteristic of hairy cell leukemia. Auer rods. These are crystalline inclusions formed from coalitions of primary granules. They are diagnostic of acute myeloid leukemia. CD markers with myeloid lineage include CD13, CD33, CD117, which are associated with myeloid lineage, found in myeloid and monocytic leukemias. CD41, CD42, CD61, which are expressed in megakaryocytes, useful in diagnosing megakaryocytic leukemia. CD14, CD64, which are specific for monocyte lineage, used in monocytic leukemias. CD markers with lymphoid lineages include CD2, CD3, CD5, CD7. These define T-cell lineage, found in T-cell neoplasms. CD10, CALA, CD19, CD22. These define B-cell lineage, found in B-cell neoplasms. Stem cell marker. CD34 is expressed on stem cells. It is important in stem cell transplantation and also seen in acute leukemia. Plasma cell markers. CD38, CD138 are used to identify plasma cell disorders, including multiple myeloma. CD71, transferrin receptor, is a marker of erythroid lineage. It highlights active red cell precursors. CD45 is expressed on all leukocytes. It is a broad marker to confirm leukocyte origin. These markers, CD103, CD11C, CD25, are associated with hairy cell leukemia. They may also be seen in other lymphoproliferative disorders. The JAK2 mutation is a molecular marker. It is strongly associated with polycythemia vera and can also be seen in other myeloproliferative neoplasms. In summary, histochemical stains like Prussian blue, LAP, peroxidase, and esterase differentiate cell lineages and metabolic defects. Inclusions like Auer rods are diagnostic for AML. CD markers define specific cell lineages: myeloid, lymphoid, stem cells, plasma cells, erythroid, and leukocytes. Molecular markers like JAK2 further refine the diagnosis of myeloproliferative diseases. Now let's review lipid storage disorders, focusing on Gaucher disease and Niemann-Pick disease. In Gaucher disease, the defective enzyme is glucocerebrosidase, leading to accumulation of glucocerebroside. On laboratory examination, bone marrow macrophages have a very characteristic appearance. They show wrinkled or striated cytoplasm, sometimes described as resembling crumpled tissue paper. Clinically, Gaucher disease can present with hepatosplenomegaly, anemia, and bone pain. In Niemann-Pick disease, the defective enzyme is sphingomyelinase, which leads to the accumulation of sphingomyelin. In the bone marrow, macrophages appear globular or foamy, filled with lipid material. A special finding in this disease is the presence of C-blue histiocytes, a distinctive cytoplasmic appearance seen in affected cells. Clinically, Niemann-Pick disease can cause hepatosplenomegaly, neurologic decline, and early mortality in severe forms. In summary, Gaucher disease, wrinkled or striated macrophages due to glucocerebroside accumulation. Niemann-Pick disease, foamy macrophages and C-blue histiocytes due to sphingomyelin accumulation.